I know that we are standing between you and lunch at this point, so we are going to stay on time. And without further ado, just the logistics for this session. My name is Ann Santa-Donato, and I will introduce myself in a minute, and then I'm going to introduce my colleague and friend, Robin Doria. The presentation, so just to make sure you're in the right room, this is the essential role of MCH professionals in reducing postpartum morbidity and mortality. This session is being recorded and also is available for continuing education, and a CE information sheet can be found at the registration desk on the conference website and in the conference app. Please silence your cell phones and other mobile devices while we are having our session. And so now it's my pleasure to introduce our presenter, so I guess that's me. I am Ann Santa-Donato, and I am the Director of Obstetric Programs for AWHONN, the Association of Women's Health Obstetric and Neonatal Nurses. I've been with AWHONN for a little over 20 years, and my background is in maternal and infant nursing. I have a master's degree in maternal infant nursing from Catholic University of America eons ago, and I am currently responsible for AWHONN's post-birth warning signs program. And in addition to that, I am the AWHONN liaison between AWHONN and the AIM program, which is the Alliance for Innovation on Maternal Health. And my full bio is on the app, so you can read more of that, because I would rather introduce somebody else. And Robin will actually begin our session this afternoon. Robin is the CEO of the Central Jersey Family Health Consortium, Central Jersey Family, that's repeated. It's a not-for-profit 501c3 organization with experience collaborating with community-based organizations, healthcare providers, governmental organizations, and consumers to assess maternal and child health needs and to provide services and programs which improve the health of women of childbearing age, infants, and children. She is published on the subject of postpartum complications and the importance of early recognition of post-birth warning signs. Ms. Doria has over 35 years of experience in maternal and child health nursing in a variety of settings, including clinical experience for all phases of obstetric patient and newborn care, as nursing faculty at the baccalaureate and associate degree level, as a staff development and childbirth educator, and as an advanced practice nurse in the acute care hospital setting, as well as nursing management and administrative experience. Hang on, I'm not done. She currently serves as the New Jersey Section Chair for AWHONN and was a member of the expert panel on maternal mortality a few years back. Additionally, she is the co-chair of the New Jersey Perinatal Quality Collaborative, a member of the New Jersey Statewide Maternal Mortality Review Committee, as well as a core partner through the American College of Obstetricians and Gynecologists for the AIM program, which, as you hopefully know, is a national quality improvement program designed to improve patient safety in obstetrics and reduce morbidity and mortality for women. Robin has also served as a consultant for the HRSA MCH AIM program in being very intimately involved with bundle development and the quality improvement work of our collaborative. Not only locally but nationally, has published about the patient safety bundles in peer-reviewed journals and has spoken around the country about the AIM initiative for many other organizations besides AMCHP. So we're both really happy to be here today. I do want to say that I'm really happy, as someone who has worked for AWHONN now for over 20 years, that we've had a wonderful relationship with AMCHP as long as I can remember. We have collaborated on various projects together, and we are continuing to do so. So without further ado, I'm going to ask Robin to come to the podium and start our presentation. Thank you.
Thank you very much, Ann. That was very nice. These are our learning outcomes for today, and they certainly are available to you in the slide set. But we're going to talk a little bit about maternal mortality and morbidity, speak specifically to the AWHONN post-birth warning signs tools, talk about how additional other healthcare professionals in the community, specifically community health workers and others, can use this tool to help to raise awareness of women on risks in the postpartum period. Neither Ann or I have anything to disclose to you today, other than we want to go to lunch too, so we'll do our best to be on time. So maternal mortality and morbidity, this is something we've all seen in the literature, in the news, people tweet, people Facebook. It is an issue, and it's one that is critical. Frankly, as a nurse for nearly 40 years, it does my heart good to finally see the attention that this issue deserves. For years, we've been heavily focused on reducing neonatal maternal morbidity and mortality, and some suggest to the detriment of the attention that we need to give mothers before, during, and after birth. And we know that women tend to concentrate much more on the health of their newborns and their families, not on themselves, especially after giving birth. Everyone in this room is an important piece of this puzzle, and everyone in this room has the opportunity to begin to address what we need to do in order to combat this horrific, if you will, situation. So if we look at maternal mortality rates over time, we can actually say that the reduction of maternal mortality is one of the greatest public health success stories in the last century. And there's many reasons for this. Probably one of the leading causes, or the leading reasons, is the attention to prevention of infection. Things like hand washing. That in and of itself helped to reduce maternal mortality. The invention and the use of antibiotics to treat infection and sepsis can be another. So we really have seen over time, and this is from 1900 through 1997. However, when we start to look at the data, and we'll show a few graphs in a minute, though that downward trend is no longer true in the US. But before we go there, I just want to take a minute to talk one more time about the definitions associated with maternal mortality. And the reason I do this is it's sometimes we can get caught up in, is this pregnancy related, is it not, is it pregnancy associated? And all of these numbers are very important in and of themselves, but they're very different, and they capture different populations of women. So just as a quick review, pregnancy-associated deaths are the death of a woman from any time, from the time of pregnancy occurs through 1 year of after birth or postpartum. So that's what we consider pregnancy-associated. Then if we'll break it down and look at pregnancy-related versus not related. And then there is actually another category, pregnancy undetermined. So for pregnancy-related, if you ask yourself, would this woman have died had she not been pregnant? If the answer is yes, then she would have, it's pregnancy-related. If the answer is no, then it's unrelated. But maybe we're not sure, given the information that we have. Did I just flip it? I did just flip it. I do that I should have read, right? So if this woman would have died, regardless of whether or not she would have been pregnant, then that's an unrelated pregnancy unrelated. Would this woman have died had she not been pregnant? Well, you know what I mean. You know what I mean? Okay, thank you. And of course, this is on record now, right? So let's take examples. A woman is pregnant, she has her baby, she has a postpartum hemorrhage, she dies. That is pregnancy related. So even when I mess up, you get it. So if I have a woman who is pregnant, delivers her baby, and then, car accident, correct, car accident. And she's the third car in a big pileup. pregnancy-related or not related? Not related. However, what if she did have that car accident and maybe had a history of postpartum depression, or she was trying to flee an unsafe situation? Excuse me? It could potentially be pregnancy-related. So there are times when we're reviewing cases at an MMRC where we're not really sure, given the information we had, and in those times, those are pregnancy undetermined, because it's not always very clear-cut whether it's a pregnancy-related or not. But for most of the data that you will look at, we talk specifically of pregnancy-related deaths, and those deaths that would not have occurred had this woman not been pregnant. So when we look at maternal mortality, and this slide is from the CDC over the past 27 years, we look from 1987 with a low of 7.2, and we look up to 2014, we are at 18 deaths per 100,000 live births. We do see a slight dip in 2012. However, we're not really 100% sure why there's been that slight decrease. And in fact, there is some literature that does suggest that the death certificate data, that the rates may actually have been even higher than what we see here. When we look at our maternal mortality rate as it compares to other nations, we are the only industrialized country that is actually rising outside of Afghanistan and the Sudan. And this really should give us pause. When we look at the maternal mortality rates rising in the US, let's look at other countries. And while it continues to rise in the US, the international trends actually show that maternal mortality is decreasing. We spend more money on healthcare than any other country in the world, with access to leading medical research, innovative technology, yet we have the highest rate of maternal deaths among developed countries in 2008. And our trajectory continues to climb, whereas we see countries such as France, Germany, Israel, Italy, Sweden, where those maternal deaths are decreasing. So what are our leading causes of maternal mortality? They've actually changed over the last decade. For example, the higher pregnancy-related maternal mortality ratios during 2009 through 2011 were really seen to be due to an increase in infection and in sepsis deaths. Maternal deaths from cardiovascular disease, however, are starting to creep up and are also increasing. Maternal deaths resulting from hemorrhage, thrombotic pulmonary embolism, and hypertensive disorders have shown to be the most responsive to intervention through appropriate education and implementations of standards of care. But when you look at this particular slide, you do see that our leading causes being cardiovascular disease, other medical causes such as non-cardiovascular, then we start to see sepsis, hemorrhage, followed by cardiomyopathy. This is probably the most disturbing slide, and this slide shows maternal deaths by race and ethnicity. Considerable racial disparities in pregnancy-related mortality exist. During 2011 through 2014, the pregnancy-related mortality ratios were 12.4 deaths per 100,000 live births for white women, as opposed to 40 deaths per 100,000 live births for black women. 17.8 deaths per 100,000 live births for women of other races. Racial disparities do continue to persist in pregnancy-related mortality, and black women are 3 to 4 times as likely to die in a pregnancy-related death as a white woman, and almost 3 times as likely to die from pregnancy-related causes as women of all other races. This discrepancy in maternal death rates between Black women and white women is almost double that of 100 years ago. So knowing this, and everyone in this room is certainly aware, there's been a great bit of media attention. And this started back in 2017. There was a ProPublica series known as The Last Person You'd Expect to Die in Childbirth. Now, if you aren't familiar with this series, I highly recommend that you take a look at this. This first woman, Lauren Bloomstein, that you see here, was a neonatal nurse. She delivered in the hospital in which she worked. Her husband was a physician, and she died from preeclampsia. That happened in New Jersey. It was an eye-opener for all of us, especially when it was the first in this series and right up there for all the world to see. That was only the first article, though, and Nina Martin and Renee Montague, both of them have done a phenomenal job in that series, so please, I highly suggest you look at them. PBS also did a news hour and multiple stories, and their series was entitled, "Why Are More American Women Dying in Childbirth?" We all heard Kira's story from Charles Johnson at the start of this convention, and that's not the first time I've heard him speak, but I have the same reaction every single time. The story is heartbreaking. I can tell you from reading and doing maternal mortality reviews for over 10 years, every time when I read a case summary and you're going through it, you think, oh my gosh, why don't they do this? Why didn't they do that? Because, and then it hits you. At the end, you know you're reading this case because this woman died, is no longer here. And these are the stories that we need to share. In both Nina Martin and Renee Montagne, when they did their series, they published other examples. The title being "Nothing Protects Black Women from Dying in Childbirth." The first woman you see on this slide is Erica Garner. From those of you on the East Coast, you may remember this case. She was from New York City. She was an activist who advocated for police reform following the death of her father, Eric Garner, after a New York City police officer placed him in a chokehold during an arrest in which he died. After the birth of her son, Eric, who is named after her dad, she suffered a heart attack. Doctors subsequently found that her heart was enlarged, and not long afterwards, she delivered in August of 2017. And December 23rd, she suffered a second heart attack, after which she fell into a coma, was left with major brain damage that led to her death on December 30th. The nurse thought her pain medication might be making, The third person that you see is Shalone Irving. Shalone was an epidemiologist at the CDC, a lieutenant commander in the U.S. Public Health Service, where her focus of her work was on trying to understand how structural inequity, trauma, and violence make people sick. She wanted to expose how limited health options were leading to poor health outcomes and undue victim blaming. She died 3 weeks after giving birth because of complications due to high blood pressure. Her mother, Wanda, shared her story at a maternal mortality summit in DC not long ago, with Shalone's daughter standing nearby. And I don't know, her mom is a school teacher, was a school teacher, and how she had the power to share her story, it will forever touch my heart, because she certainly had, let's put it this way, no one listened to her when she complained about what she was experiencing. And many of us, if not everyone in this room, knows Serena Williams, the professional tennis player who holds the most Grand Slam titles in singles, doubles, and mixed doubles combined of any active player. In 2017, she was one of the 100 highest paid athletes with $27 million in prize money and endorsements. Her daughter Olympia was born by emergency C-section after her heart rate dove dangerously low during contractions. The next day, while recovering in the hospital, she felt suddenly short of breath. She had a history of blood clots. She knew what she was experiencing. She shared that with her healthcare providers. And she, again, was not heard. Telling the nurse near her, as she was gasping for air, that she needed to have a CT scan done, because this is what had been done to treat her in the past, and she needed to have IV heparin to thin her blood to prevent further clots. The nurse thought her pain medication was making her confused. That's why she was saying these things. She insisted, and the doctor performed an ultrasound of her legs. She's like, my legs, that's not what I'm talking about. So we're talking about three women who died, two of which died. Serena Williams was a near miss, who very well and potentially those issues could have been prevented. There have been other articles we can see in the New York Times, If America Loves Moms, Why Do We Let Them Die? The Times Magazine, Why Are Black mothers and babies in the United States dying at more than double the rate of white mothers and babies? And even in New Jersey, and I'm sure in your home states, hopefully there has been a focus, and for us, this title in a local magazine and online and paper, keeping the focus on New Jersey's high maternal mortality rates. The picture of the couple that you see there, I'll be talking about in a moment. So we're getting traction. We are getting noticed. This issue is finally being elevated to where action can be taken. One more thought. When we talk about maternal mortality, we need to look at when these deaths occur, and many people assume that it happens in the hospital. But it's important that we know the timing, because many of the risk factors, many of the complications that are experienced with not only mortality but also with morbidity can't be clearly identified before a woman goes home from the hospital. And in fact, more than 50% of deaths specifically occur in the postpartum period. This graphic shows that over 50% occur, then it's actually 53%. And of these, 18.2% occur in the immediate postpartum period, those first 6 days after mom has her baby, while 21.3% occur between day 7 and day 14, so that's second week. And then an additional 13.2% occur between 21.3 between 7 and day 41, and 13.2 between 42 days and 1 year. That's a lot of women that occur in that later period of time. So considering this data, it's important to note that once a woman goes home from the hospital, she needs to rely not only on her own ability to recognize if something is wrong, but her family also needs to know what some of those signs and symptoms might require prompt medical attention. What I'd like to do now is turn this over to Anne to talk a little bit more, not about the maternal mortality side, but maternal morbidity. Severe maternal morbidity being a unexpected outcome of labor and delivery that results in either short-term or long-term consequences. If we look, we're talking about women who might have had or experienced an ICU admission during her delivery, after her delivery, and/or had received 4 or more blood transfusions during that time. It's also on the increase, and we'll be talking a little bit more about that.
Thanks, Robin. And from the remarks I'm about to make, we're going to then segue into Robin's experience in New Jersey implementing the post-birth warning signs program in a community health setting. So before I start in on some of the information about severe maternal morbidity, I'd really like to just get a show of hands of how many of you in this room are responsible for the direct care or consultation with moms after they've gone home from the hospital. Okay, how many of you are responsible for those moms in the hospital? Okay. How many of you are responsible for the people who are responsible for caring for the moms when they go home from the hospital? What do the rest of you do? And I'm not being facetious when I say that, but I want to know that the folks in this room, that you all have a vested interest in making sure that the people who are working with moms after they go home from the hospital, or that if you're responsible for the development of the folks who are doing that kind of work, or you're in your state health departments, have a really clear understanding of why this is so important. Robin just described it beautifully on that slide, where all that green are deaths that occur in the postpartum period. So the majority of deaths occur during that time. And that's something that really didn't come to the forefront until just a couple of years ago, when we started getting a lot more traction on this. I'm going to talk a little bit about the severe maternal morbidity stats, and then we'll start talking about the program, and then lead into how this can be implemented in your communities. So without further ado, the glasses come off. Okay. So on this slide, what you're looking at is the rate of severe maternal morbidity based on whether or not, so the orange line is the overall rate of severe maternal morbidity, and like mortality, those rates have continued to climb to the point where now up to 50,000 women every year, 50,000 women every year experience a severe morbidity during childbirth or after childbirth. And again, many of these circumstances are preventable. So that's another way of reinforcing what we're talking about today. The blue line is the rate of morbidity associated with women who have had blood transfusions. And so you see that the rates are kind of like they climb in parallel to the overall rate, because if a mom gets to that point where she needs a transfusion, then she's usually seriously ill. And then the morbidity rate among women without transfusion, so they occur, but they have sort of maintained a steady state with a little bit of a rise, not so much as the more severe cases of maternal morbidity. So just wanted you to have that understanding. All right. So what is it that's causing all of this morbidity and placing moms at risk for death during pregnancy? So these are just some of the factors. And I wanted to point out to you also that this session is being recorded, so you can go back and refer to the slides whenever you want after the meeting. But the one handout that we included is a reference list. So all of the citations that you see on the slide are in your app or on your online app on your computers as a full reference list. So don't worry about copying down citations, okay? We highlighted just a few of these. Increased maternal age, moms who have babies at a later age. Now, obviously, many women who have babies at an older age do just fine, okay? But the reality is, the older one is, the more prone to complications you are, okay? So, and that is regardless of your race, your socioeconomic status, et cetera. Our bodies just don't accommodate pregnancy as well as when we're 47, as well as they do when you're 24 or 25, barring other complications. Pre-pregnancy obesity, as all of you know, obesity is an epidemic in this country, and obesity has significant consequences, or can have significant consequences, for women who become pregnant. I can't wait to see tonight's episode of This Is Us, because this is exactly what they're going to be talking about. So Kate is pregnant, and so get your pens out in case we have to send emails to the network. But yeah, so she's 28 weeks pregnant, and some complication occurred. She broke her water, and so we're going to see what happens tonight. Bad example, but it just was sort of on the top of my head. And I hope I'm not violating copyright laws because we're being taped. Okay. Pre-existing chronic medical conditions, all right? Diabetes, hypertension that pre-exists pregnancy, heart disease diagnosed heart disease that pre-exists pregnancy, et cetera, and cesarean delivery. I hope that all of you are aware that the whole push to reduce the cesarean, pun intended, the whole push to reduce the cesarean section rate in this country is predicated upon the fact that, like it or not, cesarean delivery is major surgery, and major surgery is associated with increased morbidity compared to spontaneous vaginal birth, okay? So there's complications associated with cesarean delivery, and in fact, some of those blood transfusion statistics that we just talked about are maybe due in part to that rising cesarean section rate. So, and we could do a talk just about that. So let's go on. So let's talk, I'm just going to, for a couple of minutes, talk about physiologic changes in pregnancy. Again, this could be a talk all by itself. But I wanted to highlight a couple of key factors that are changes that take place in a woman's body that take place for a very good reason. But at the same time, it's a little bit of a catch-22 because it can also place the mother at risk. And those two factors are cardiovascular changes of pregnancy and the hematologic changes of pregnancy. So there's a number of hormonal changes that take place that are perfectly normal, and they just simply relate to the woman's normal physiologic adaptation during the pregnancy. But I want to talk about the cardiovascular and hematologic changes. So cardiovascular changes, what do you think needs to happen during pregnancy to support the growing fetus? The blood carries oxygen. Oxygen needs to go to the mom, and oxygen needs to go to the baby, right? So the normal natural process is that the mother's blood volume will increase 30 to 50% during pregnancy. Normal. Heart rate increases 20% as a result of the increased volume that's circulating, okay? So if you put, a garden hose full force, that's a lot of pressure, and it's normal, and hoses don't burst necessarily. But for a woman who's already has a compromised condition, that additional volume may place her at very high risk for either cardiovascular decompensation or something even, or hypertensive disorders or exacerbation or increasing in severity of the hypertensive disorders. The cardiac output increases to accommodate that increase in the blood volume, and the heart has to work harder. So again, under normal circumstances, this is a normal physiologic process that takes place in order to support the growing baby. But it can also place mom at risk. The hematologic changes. Again, the hematologic changes that take place for primarily one reason, and that is to ensure that most moms don't hemorrhage after they give birth. Because what happens to that very big uterus after whether the mom gives birth is that it contracts down. And guess what? That bleeding usually stops. And the reason the bleeding usually stops is because of the clotting factors that are present in the mom's body in increasing amounts. So we refer to pregnancy as a hypercoagulable state, so an increased propensity for blood clotting. Again, another catch-22, because under normal circumstances, mom gives birth, the uterus contracts down like it's supposed to, and mom does not bleed to death, all right? But for people who are at risk, people like Serena Williams, who has a history of blood clots, the pregnancy places her at much higher risk because she already has a clotting defect, okay? Those normal mechanisms are, they're the best of all worlds and sometimes the worst of all worlds. So that's just a very quick overview of some of those key changes that take place during pregnancy that in and of themselves may place moms at risk. So just to summarize then, what are some of the, we kind of alluded to them, but what are some of what are some of the conditions that place moms at very high risk for death and morbidity after the birth of the baby? So they include cardiac disease, hypertension, hemorrhage, venous thromboembolism. So the difference between venous VTE, venous thromboembolism, and pulmonary embolism is that the VTE typically occurs in the lower extremities or in the groin area, okay? Groin area clots are typically referred to as deep vein thrombosis. So that's the differentiation between the two. Infection and sepsis. Sepsis is the severe form of infection, and that can be deadly if it goes unchecked. And then we can't not talk about maternal mortality without talking about severe postpartum depression and your ability to differentiate or help moms differentiate what is, I'm just not feeling right and I'm kind of a little blue after the baby comes, to, I can't handle this. I don't know what I'm going to do next, and I feel like I want to jump out of a window. So we have to put maternal mental health issues on this list of contributors to maternal morbidity and mortality. Okay, so you saw this slide a little earlier, just reinforcing the fact that this is so important because so much of these morbidities and deaths occur during the postpartum period. So I want to switch gears a little bit and talk about how and why AWHONN got involved in all of this. We, as Robin said, the media took this all up by 2017, early 2017. But many of our organizations, including AMCHP, has been working on the issue of maternal mortality since 2012, 2013. So we're really, really grateful that it finally got the media attention it deserves. But here we are back in the wings working on it for quite some time. So we talked just a little bit or alluded to the Alliance for Innovation on Maternal Health. So AWHONN is a primary partner and on the executive committee of the AIM program. And we're very proud of that because we are there to ensure that nursing's voice is heard along with the other collaborating organizations. And I do want to say that one of the beauty things about the AIM program is that it cannot exist without collaboration. And so the number of collaborating organizations has simply grown and grown and grown. And we have expanded the reach of AIM over the last, so AMCHP was also an executive team member, so they were there at the beginning. But we have placed more emphasis on health equity and disparities. We have also placed much more emphasis on bringing in more community health and public health organizations, and we are also paying much more attention to bringing in the voice of the mother, okay? But AWHONN got involved in this with the onset of AIM, but we also, at the same time, were working on other projects. So our postpartum hemorrhage project began in 2015, went through 14 to 16, and that was funded and supported by Merck for Mothers with a generous grant, as was our post-birth warning signs program, phase 1. And we have a multitude of other AWHONN resources that we just don't have time to talk about now, but I really want to focus on post-birth warning signs. So early on, and this was published in 2016, this is Robin and her colleagues' work to talk about strategies to reduce maternal mortality during the first year after birth. And again, these two articles that I'm talking about right now are in your reference list, so they're easily accessible. And at the same time, AWHONN was beginning its work on looking at the postpartum period and postpartum warning signs. So phase 1 of the project was to conduct focus groups in 2 states that had been involved in the original postpartum hemorrhage project, which included New Jersey, Georgia, and the District of Columbia. So we had a couple of facilities in New Jersey and then a couple of facilities in Georgia that were involved in that program in post-birth warning signs phase 1. So here's what we found. Based on the focus groups with nurses in hospitals, majority of the educational messages focused on the baby. So if you're working out in the community with postpartum moms, you know that frequently everybody zeroes in on the baby, which is absolutely important and it's critical. But what we also know from the literature is that mothers tend not to take care of themselves to make sure that the baby is taken care of when they come home from the hospital, right? So that was something that was validated through the interviews that our lead primary investigator, Trish Supley, had with these nurses. And the other thing we found is that women were receiving inconsistent or inaccurate information about maternal post-birth warning signs. So the messages were kind of all over the place. Or that the education didn't focus on warning signs at all. If a mom had a nice normal baby with no complications, she got information about breastfeeding, she got information about self-care in general, but nothing related to, hey, you could be at risk for these complications. And that the warning signs are taught to women, so conversely, warning signs were only taught to women who had known complications. So that was very eye-opening. And that revelation led to our phase 2, which was developing the tools and then doing an implementation project as the second part of the post-birth warning signs project, which was then and continues to be referred to as empowering women to obtain needed care. So we are very proud that we just received, this is all after all of this, we just received another grant from Merck for Mothers to do a wider dissemination of our post-birth warning signs. So we're really happy about that. But this phase 2 was all about implementation. And we wanted to make sure that we were raising awareness and educating clinicians about key postpartum complications, empowering women to know the signs and get care quickly using a standardized patient education process, and to make sure that all healthcare workers were involved. Now, for the phase 2 of our project, we zeroed in primarily on nurses, secondarily on doctors, and not really on community health workers. So that's why we're here today, okay? And these are the key messages that we convey through this work. Number 1, to recognize the symptoms and signs of childbirth complications that can occur after discharge. To respond by calling 911, going to the nearest hospital or urgent care center, or calling your healthcare provider, depending on the severity of the symptoms. And to remember at every encounter, to tell the healthcare provider, including EMS personnel, emergency service personnel, urgent care personnel, a social worker, that the mom had given birth. And I say given birth versus had a baby because we have recently changed our tools to reflect the fact that moms who have had perinatal loss are also at risk. And so to make the forms and the tools more sensitive, we've changed our language a little bit. But to make sure that the mom reflects the date that the baby was born or the date the mom gave birth, and because the symptoms could very well be related to the pregnancy. So a mom who is 2 weeks postpartum, and if you're seeing her or some of your colleagues are seeing her and she's complaining of a headache, well, yeah, it could be fatigue. It could be, normal from, consequences of the pregnancy. It could very well be severe preeclampsia. So that's where you have to probe deeper. So I'm going to segue over to Robin now again, and she's going to talk about the experience in New Jersey. But all of this led to the development of our AWHONN post-birth warning signs program. Later on today, you can go to the website, www.awhonn.org/postbirth, and see all of the resources that are available, but that's not the point of why we're here today. So I'm going to turn it back over to Robin so she can talk about the New Jersey experience, and then we'll come back to me to finish up, okay?
Thanks. So what did we do in New Jersey? We had a family that experienced a maternal loss, and it actually was the couple that you saw earlier. Her name is Tara Hansen. Tara was a 29-year-old New Jersey resident, had an uncomplicated pregnancy, first-time mom. She was a school teacher, and she died 6 days after giving birth to her child of an uncontrolled infection. What makes this so poignant is that she did all the right things, as did those other women that I showed you, the 3 that we profiled earlier. She did everything right, according to what we would say. She went to her classes, she went to the doctors, she ate well, she exercised, and she still died. And what, in this particular case, and what started the Tara Hansen Foundation, and this is the story her husband Ryan tells, and that is, when they were in the hospital, Tara didn't feel quite right. And prior to discharge, she complained of her bottom hurting. Now, for those of you who've had a vaginal birth, your bottom hurts after having a baby. This is true. However, her comments to this effect were kind of ignored and just assumed to be normal childbirth pain. And she said, I don't know. And of course, retrospectively, looking back, she went home with an elevated pulse and a very slight, albeit elevated temperature. She got home, and as Ryan describes, they were a family for 36 hours. At that point, she said, something is wrong. I just don't feel right. They went back to the hospital, and in fact, she had an infection at her episiotomy site, was septic, and died shortly thereafter. So Ryan, a few months later, came to his parents and said, we need to do something. We need to do something to prevent this from happening to any other family. And what they did was start the Tara Hansen Foundation, which is a foundation not unlike the foundation we heard for, that Charles Johnson described for his wife. And they look to provide education to folks within our state on postpartum warning signs. But one of the thoughts that they had was to have a maternal health awareness day. And back in 2017, a small group of us met and said, what can we do? We need everyone to be involved. And we engaged a legislator in New Jersey, one of our state senators, and spoke to him and said, we want to have a day in honor of women to raise awareness about women's health and specifically about postpartum complications. And at that point, again, back to the puns, no pun intended, Maternal Health Awareness Day was born. Legislation was signed by then Governor Christie in 2017, and we had our first Maternal Health Awareness Day. In the past 2 years, we've gotten a little bit more sophisticated. We're fortunate, Tara's mother-in-law is actually a communications specialist, as is Ryan, to tell you the truth, but she works in the medical school, at Robert Wood Johnson Medical School in New Jersey, which is affiliated with Rutgers University. And through that university, we developed, and through their help, a media kit that we put together that included flyers, posters, news releases, social media support, what you should tweet, what you should post. Our PowerPoint presentation, we have a standardized presentation that we then send this media kit out to all of our partners, and by partners, any stakeholder in the state who's interested in this particular topic. Last year, on January 23rd, 2019, or this year rather, 2019, and if you notice, it's 123 and for moms is our hashtag. We actually had all of our hospitals participating in Maternal Health Awareness Day, many of them using this PowerPoint, which in turn can be modified so that it can be specific to that hospital or healthcare system. And what it includes is a campaign that we put together. And this campaign is twofold. It's focused at women and helping women to feel that they, in fact, should trust their instincts, should speak out when they feel something is wrong. And the second component to that is for providers to stop and listen, and we call it the Stop, Look, and Listen campaign. For the providers, this piece we're talking about for them to stop. If a woman comes to you with a complaint, stop what you're doing, stop typing, stop texting, stop, entering into the computer, whatever it is. Physically look at the woman while she's talking to you. And then, in fact, conduct an examination or do what you feel might be appropriate given the information she's sharing with you. And then listen. to mom. Listen to what she's telling you. Do not just dismiss what she's saying as she's just complaining, she's just postpartum, she's just ... We've taken this campaign, and for the past 2 years, we've actually delivered this particular lesson to the medical students at the medical school and had it telecast at other conferences, at other campuses. We had nursing students, public health students being part of this particular educational campaign. And we're going to continue this campaign over the next, for as long as we can. And in fact, we're working with National ACOG to see if we can raise awareness and possibly make Maternal Health Awareness Day something in every state in the United States. So far, we have Pennsylvania, who this year also celebrated Maternal Health Awareness Day on January 23rd. So, as Charles Johnson said, we believe this is not just a women's health issue, this is a human rights issue. And when he said, educate, advocate, support, legislate for our women, that's exactly, we hope, what we're doing with this particular campaign. But in addition to this, we recognize that we need to have better education and a better spread on what are those postpartum warning signs. Because people don't recognize, although over 700 women in this country die after having given birth within that first year, most folks don't even realize that unless you're in the business, like we are. So with our spread, we've gone to our hospitals and engaged them to implement the post-birth warning signs that Ann just described in every one of our 49 hospitals in New Jersey. So every woman will have the same sheet of paper when they go home. They will have been given the same type of information that they need to get to know and to recognize. But not only for her, our hope is to have not only mom, but her family, and whoever she describes as her family. All of these people, so the more people that know, when she complains of that headache, when she complains of not feeling quite right in her chest, when she does have a fever, all of those things can be triggers to say, is there something that needs to be addressed, and not assume that it's normal childbirth and it's something that we normally have. The next step that we've gone is we realize that there's a whole nother layer of a healthcare professional out there that could be very, very important, that works with the community at the grassroots level. And that's our community health workers, our doulas, our lactation consultants, our community peers, folks in the community that can actually also be a resource for mom. And engaging this group through our community-based organizations, through our faith-based organizations, we're starting to get this same message, this post-birth warning signs message to them, so we have a statewide spread. We recognize it's not one or two people, it does take a village, and that is what our approach is. This is what the handout looks like, and I think it's important. It's relatively easy, it's quite colorful, catches your eye, and we recommend that it be put on the fridge. There are other types of tools, there are magnets, there are different types of versions of this that can be used. And it actually tells you, call 911 or call your healthcare provider. It tells you what to do if you're experiencing these types of conditions. And as Ann discussed earlier, one of the eye-opening pieces to the research that we had is that the nurses were very selective in who they shared this information with. And unfortunately, we know that complications can occur in any woman, regardless of their situation. So suggesting a way in which to broach this topic, because if nurses are concerned and uncomfortable with sharing this message with their patients, think about community health workers that may not have as much information or education on this particular area. So a suggested script we've been using is, although most women give birth, recover without problems, any woman can have complications after giving birth. Learning to recognize these post-birth warning signs and knowing what to do can save your life. So now I'd like to go over with you some of those warning signs so you know what to do and whether or not you should call for help, call 911, go to your healthcare provider. And to emphasize sharing this, if you're not able to do this education with the family or with the with others, tell mom, it's okay, this is what you need to do, and share with friends and family, and to post.
Okay, I know that we're running short on time, right? Okay, what do we have, like 2 minutes left? All right, here's what I'm gonna do, because I wanna get to, hopefully get to a video that occurs at the very end, because we want to end on a positive note to say that these things that we're trying to do can be very effective. So what I would like to do, though, is just take a moment to scroll through the following slides, because what you can't very well see on this particular slide, I'm going to show to you in close-up. So what I'm going to do is just scroll through them so that you can see them and come back to them later when you download the presentation, and then we'll go directly to the video, okay? So the whole purpose of this tool that you're looking at now is a tool for nurses or other healthcare professionals, or even a community healthcare worker who has been trained in these things can review with a mom either in the hospital or when she goes home from the hospital. And what I wanted to tell you is that the tool that Robin referred to, the big colorful tool, that I have cleared with AWHONN headquarters, that if you're working in a community health clinic or a community health setting where you're seeing these moms after they have left the hospital, you can download that tool, the big bright red and yellow colorful one. You can download that tool from our website free of charge and distribute it, as long as you distribute it within your own facility, okay? And come to me afterwards and I'll get you the web address and all that. So risk factors. So what we do on this form is just look at the risk factor for pulmonary embolism. We define it, what are the signs, and what do you do about it, all right? So that's the next group of slides, and again, you'll go back to them when you have time and just read through them a little more carefully. Then we do cardiac disease. What's the definition? What do I look for? And what's the immediate care need? Same with hypertension. Same with hypertension continued, preeclampsia. OB hemorrhage, what am I looking for? How do I define a clot, et cetera, and how do I get care, okay? Venous thromboembolism, VTE, that we talked about earlier. What is it? What do I look for? What do I do about it? What's an infection? All right, a lot of women don't necessarily know what to be looking for, so we're trying to help the nurses or the other professionals who are teaching them. So this is a teaching tool for the provider, right? But to make sure that the messages are standardized. What is postpartum depression? Helping moms differentiate the blues from something much more serious. And if mom indicates that she feels like she wants to commit suicide or harm somebody else, that's a 911 call, okay? The follow-up appointment, critical. So if you're seeing that mom, a week or two after she delivers, and because she has a complication, you want to make sure that she's in the healthcare system and seeing the specialists or whomever that she needs to see. And then here's our story. So hopefully this will work. Cody, I'm counting on you. This is a woman who was given the information and ended up coming back to the hospital with a complication, but in her words, she was saved because she had the Save Your Life handout readily available. So let's see what happens.
Okay. I started showing some signs of mastitis, actually.
Volume.
And then I started getting chills, and I suspected fever. And then later that day, I started getting some more intense symptoms. I just didn't really feel like myself. I called in to the OB and got a prescription for my mastitis. And within the next couple of days, I just kind of worsened, actually. You know, the fever and the chills had gone away, and the mastitis started to feel a little bit better. But overall, a feeling in general, my overall health, I kind of knew something was off. I started having really rapid heartbeats, even walking from the living room to the kitchen, and started noticing that my breath was a little off as well. It wasn't like I was gasping for air, like some people explain it. Mine was more of, if I would take in a breath, it would kind of cut, and then I would start coughing after that. I literally picked up the sheet and showed it to my mom, and I said, shortness of breath, 911. I said, we're going in. And she kind of looked at me like, I think you're just having a bad anxiety attack, and it's really stressful going to chew, you're tired, you're not getting sleep. And I just said, Mom, something is not right. And I did. I pointed to the sheet, and I said, we're going. So we went to the ER. You know, they did my pulse oximeter and everything, and my pulse was about 163. And so immediately they sent me back in the room, started drawing labs and everything, and putting in the orders, and did the blood work to kind of see if there was a possibility that it would be a clot. They did the CAT scan, they did the chest x-ray and everything like that. The x-ray came back normal. And then he came in and said, we got the results of your CAT scan, and there's a small clot in the right lower area of your lung. So at that point I cried, you know, not really sure what it entailed. So I had a mix of emotions going through my head, you know, thankful that they caught it, scared to death that I wasn't going to go home to my girls. I had a 9-day-old newborn baby, two almost 3-year-old that, you know, I was for everything. So really just kind of emotionally scared me. People have different complications with everything, but that kind of fear of not knowing if you're ever going to hold your baby again. And the hospitalist was wonderful. They showed that I was on prescription and Lovenox as well. That wouldn't affect my breastfeeding. They enabled me to bring my baby back to the hospital, because she was only 9 days old at that time, to continue breastfeeding. So my experience, while, you know, different than being at home with her, they did everything they could to keep it as normal as possible, keep her with me, and make sure the medicines I was on, that I was able to continue breastfeeding, and I currently still am right now. You know, they kind of were surprised I wasn't cesarean, I didn't have any risk factors, anything like that, but it still happened, and it still can happen.
Okay, so like Serena Williams, Sharon persisted, but she had an extra tool at her fingertips that some of these moms who have not been so fortunate didn't have. So, is this the cure-all? No, because we know that it takes a village. We know that it takes a concerted effort on the part of every member of the healthcare team, whether you're in the hospital or working out in the community. But we hope that by using tools such as the AWHONN Post-Birth Warning Signs Save Your Life tool, that we will continue to make a difference in the lives of women and families.
Feel free to ask any questions, make any comments.